Hi, I'm Dr. Paul Shyn, and this is an introductory talk on using ultrasound contrast during cross-sectional interventional radiology procedures. So, why use ultrasound contrast during interventional procedures? Well, first of all, ultrasound has many inherent advantages as a guidance modality for interventions. The real time component of ultrasound is extremely valuable. This helps make it a very quick and efficient tool. Color flow Doppler gives us real-time visibility of vasculature so that we can avoid those structures as we advance our needle to our target. And of course, ultrasound does not involve the use of ionizing radiation. Ultrasound contrast agents further enhance the use of ultrasound. Number one, it's an alternative to iodinated contrast agents during CT-guided procedures. Patients that have a contrast allergy or who have acute renal failure where you want to avoid use of IV contrast can be an advantage as well. When using ultrasound, adding ultrasound contrast may improve lesion conspicuity, making it possible to target a lesion using ultrasound that you might not otherwise be able to target. It can also help you identify and target the viable non-necrotic portions of tumors, and it may help you characterize a lesion at the time of the biopsy and may even impact your decision on whether or not to do the biopsy on a particular target. Having ultrasound contrast agents available may further improve efficiency by allowing you to book a larger percentage of your cases in an ultrasound only suite as opposed to a CT room with ultrasound. In other words, for those cases where you think that ultrasound might not work and you want CT as a backup, perhaps you're booking those cases in a CT room, and now you may feel more comfortable avoiding that use of that resource, more expensive resource. So here's an example of a patient with a large metastatic tumor in the liver from breast cancer. And you can see on the ultrasound image, the tumor is relatively isoechoic, very faintly visualized, but when we use ultrasound contrast, the tumor becomes much more conspicuous and allows us to very confidently do this biopsy. So what will you need to do a contrast enhanced procedure? Well, you need an ultrasound unit that has the appropriate software package loaded. In our department, the contrast package is loaded on our GE E9 units. And we typically used a curved array for abdominal applications. You might use a different probe if appropriate. You'll need at least one contrast dose package. Lumason is the agent that's currently approved for use in the abdomen. You can ask our CSIR nurses. They know where this is stored and they can bring that into the room. Each package contains 4 items that I'll go over in just a minute. And you'll also need a 10 milliliter injectable saline flush. That's a preloaded syringe that we store in each room in drawers. And a 3-way stopcock. We also are going to have a screening form, which is currently under hospital review and should shortly be approved. This is what the form looks like. The first question is, have you ever had an allergic reaction to a microbubble contrast agent? In our case, our main interest here is Lumason. If they've had a reaction to Definity or Optoson, those actually do not contraindicate the use of Lumason, but we still want to know it. It might have a slightly increased association with reaction. The same is true for asking if the patient has had a severe allergic reaction or anaphylactic reaction to any other medications or agents. Again, that's not a contraindication, but may portend a slightly increased risk of reaction, and it just makes us more aware that we want to be prepared to deal with a reaction. For pregnancy, we are going to screen the patients for pregnancy. If they're not sure, we can get a pregnancy test. We are going to avoid using contrast in pregnant patients. And similarly, if they're breastfeeding, we're going to avoid use of contrast, even though there are no known harmful effects in pregnancy or through breastfeeding, but we're going to avoid using the contrast in these scenarios. If there was some extreme situation where you really felt that the benefits would outweigh any potential risks, this would probably require a consult with the OB-GYN service and informed consent before using contrast in a pregnant patient. Also, if they're lactating, breastfeeding, we're going to avoid using it, but if we do, for some reason, give it to the patient, we're going to recommend that they pump and discard once within 24 hours prior to resuming breastfeeding. Written consent is not required, just like we don't require it for other contrast agents that we use in our department. The risk of reactions is actually lower with ultrasound contrast than with iodinated contrast agents. We will ask about prior allergic reactions to ultrasound contrast. We will screen for pregnancy and breastfeeding. Keep in mind, if you're wondering about right to left cardiac shunts, cardiology routinely uses these contrast agents in patients with intracardiac shunts, and that's not a contraindication. We do keep contrast reaction kits and, of course, a code cart in the CSIR area. To prepare the contrast agent for use, we're going to do this within about 10 minutes of expected use during the procedure. Just before we inject the contrast, we're going to shake it up a bit or agitate it so that it's not settling. And this is what the kit contains. It contains 1 vial of the Lumason powder, which we will reconstitute with a 5 milliliter syringe of diluent. There is a plastic adapter that has a spike on it and a lure lock connection, and there is a plunger that we will screw into the diluent syringe. You can see that the syringe has a white plastic safety cap. We'll twist that off, leaving the one part, half of it on the syringe, and the distal half twists off. So we'll pop off the blue cap. Notice that we have a 3-way stopcock handy. We will screw in the plunger into the back of the syringe. Then we take this adapter and we can pull the green cover off the spike end, and there's a green tab on the lure lock connecting side that we'll flip up, and that's where we will attach the diluent syringe. And then once we've attached the syringe to the adapter, we'll push the spike into the Lumason vial. We'll then shake it up. You will inject all the diluent into the vial and shake it up until it's all dissolved. Usually that takes about 20 seconds or so. Then we draw it back up into the syringe. It looks cloudy, of course. It contains microbubbles. The syringe will hold then 5 mils of the contrast agent, and that translates into 2 doses, 2.5 mils each. Then we attach the syringe to the 3-way stopcock. Notice that we're going to attach the contrast syringe so that it is in line with the IV tubing. That minimizes mechanical disruption of microbubbles in the stopcock. And then we'll attach the saline flush to the side port, the 10 mils saline flush, and then we'll finally attach the 3-way stopcock to the IV tubing. Preferably attach it as close as possible to the IV insertion site so that it doesn't have to travel through a significant length of IV tubing. Larger gauge IVs are better than small gauge IVs. And then again, it's 2.5 mils per dose, so that means you have 2 doses per package or per syringe. And this will give you about at least 5 minutes of enhanced imaging per injection. So your typical case might begin by a preliminary ultrasound scan using normal settings to sort of assess the target organ and visibility of the target lesion and your need for contrast, for example. You may also already have the patient positioned ideally for the procedure. Then once you've done that, you can do the prep and drape of the patient and then do your first injection to assess the contrast enhancement pattern and conspicuity of the target lesion. You might then use the second injection for the actual needle placement. And if needed, you can use multiple doses. You can use more than 2 injections if you need to, but that's going to be quite uncommon, I suspect. And it may be that as you get more efficient, there may be cases where you are able to do the planning and intervention with a single injection of contrast if you're particularly fast. On our particular system, to activate the contrast software, there is a contrast button that's located just above the manual keyboard on the right side there in the middle of the console. And so you'll push that, and that will bring up this split screen display. Notice that on the left is sort of the standard ultrasound image, although it is a low power or low mechanical index image, so the image quality is not quite as good as what you're used to. And then on the right side, we have the contrast image that is contrast only. On the bottom left, you see the timer clock. This one is T2, meaning it's the second timer clock, and it's reading out at 1 minute and 5 seconds. This is something that you're going to activate with each injection of contrast, as I'll show you. On the touch screen, this is where you activate the contrast clock during the injection. So when you ask the nurse to inject the contrast, you will, as she starts to inject, you'll push contrast clock 1 if it's the first injection, or contrast clock 2 if it's the second injection. That way you will have a record of the timing of the contrast appearance on your stored images. Remember that to store cine loops, which you'll want to do, you'll need to press on our unit the P3 button. This is what we use to store cine clips. Each clip is usually about 15 to 30 seconds, the way our units are configured. You will probably need to push this repeatedly as needed to store appropriate clips, which can then be sent to PACS. So let's look at an example. This is a very large tumor, certainly could be biopsied without contrast, but notice that on the ultrasound image, it is actually difficult to distinguish the areas of viable from necrotic tumor, whereas on the contrast-enhanced CT, it's fairly obvious where the necrotic areas are. So what we did here was we used contrast. You can see this is the dynamic injection of contrast, and you can see that slowly contrast begins to appear in the liver and the viable portions of the tumor, and throughout the time of injection, you can see that as the contrast is injected and circulates, that the necrotic areas never show enhancement. So we placed our needle, which you can see under the real-time ultrasound image on the left. On the matching contrast-enhanced image, it's harder to see the needle, but by looking at the screens and comparing them, we have a pretty good idea of where our needle is in relation to the contrast enhancement. To improve the visibility of the needle on the contrast image, I find that jiggling the needle or moving it back and forth can really help confirm where the tip of the needle is if you have any doubt. So in this case, the needle is clearly within the enhancing viable portion of the tumor. And this is just a static image showing that the needle is placed into the enhancing viable portion of the tumor. Where the use of ultrasound contrast really shines is in targeting lesions that are simply not visible on ultrasound alone. This was a patient with pancreatic cancer. The 1 centimeter metastasis is actually subtle on contrast-enhanced CT. It's very likely that this would have only been transiently visible on contrast-enhanced CT, and so this could have been a challenging CT-guided biopsy as well. When we initially looked with ultrasound, real-time ultrasound, we simply could not find this lesion. So we injected contrast. As is the case with most metastases, it showed very nice washout, and so it becomes hypoechoic very quickly, and this allowed us to very accurately target this lesion for a diagnostic biopsy of a pancreatic metastasis. So just some, although this is not a comprehensive discussion about ultrasound contrast characteristics of tumors, malignant tumors usually do show significant washout. In the liver, HCC washes out more slowly and to a lesser degree than metastases. And while this may seem paradoxical given our experience with contrast-enhanced CT or MRI, that's because ultrasound contrast is a purely intravascular compartment contrast agent. It doesn't move into the interstitial compartment. Hypervascular tumors may show a brief early arterial phase of hyperenhancement followed by washout. Hemangiomas will remain enhanced following blood pool, as you would expect. And in the kidney, tumors also will show variable enhancement, and often with washout. Malignant tumors will usually show washout in the kidney. Notice that there is no urinary excretion of contrast by the kidney. This was a case of a kidney mass biopsy that we did. The patient underwent an MRI and was not given IV contrast because he had acute on chronic renal failure. His eGFR was well below 30. I think it was actually below 20, and because of concerns about NSF, we did not use contrast. So the mass was interpreted as suspicious for renal cell carcinoma, but there was some question about we didn't know if this was an enhancing solid mass. Could it have been a complex or hemorrhagic cyst? And so we were asked to do a biopsy. With the patient on the table, we went ahead and did a contrast ultrasound. Renal failure is not a contraindication for the use of Lumason. And you can see that as we injected the ultrasound contrast agent, we see the kidney perfusion and immediately perfusion of the mass. So we knew it was a solid enhancing mass, and then we proceeded to the biopsy. In this case, we use CT guidance for the biopsy to avoid spleen and stay kind of in the peripheral cortex of the kidney. And that did turn out to be a renal cell carcinoma. Just a few tips. Place your focal zone for the ultrasound during contrast mode deep to the target, so that because the power tends to be greater at the level of the focal zone, that tends to cause more microbubble destruction. So place your focal zone just deep to the target, and then avoid increasing the gain unless you have to, because that will increase microbubble destruction. And then if you do want to clear all the microbubbles at the end of a injection, toggle out of contrast mode, turn on color flow Doppler, and just sweep over the targeted area and the major blood vessels to eliminate the bubbles. And then you're kind of cleared for a second injection if you want. This is just another example of a case where we initially used an ultrasound and color flow Doppler ultrasound to place a needle avoiding vascularity. We got the needle to the mass, and then we gave contrast, and we noticed that the central part of the mass was poorly enhancing and possibly necrotic, whereas the periphery was hyper enhancing. So we repositioned our needle to biopsy the more hyper enhancing portion of the mass and to improve the odds of a diagnostic biopsy. So just a recap of workflow. You'll screen the patient before giving contrast. You'll prepare the contrast agent. Start off with a preliminary routine ultrasound scan for planning and positioning with standard settings and power. Then switch to contrast mode. You'll have the nurse inject 2.5 mils per dose per injection, and then as soon as she injects the contrast, she'll turn the stopcock and immediately flush 10 mils of sterile saline as a flush. You will push the timer button at the beginning of the injection. Remember to record your cine loops repeatedly during the injection to record the findings, and then remind the technologist at the end to send all the ultrasound images, including the cine loops, to PACS. Just a word about reimbursement. There is reimbursement for the contrast agent itself and for both technical and professional components of the contrast enhanced imaging. Reimbursement is on a per tumor basis, so if you're doing 2 different lesions, it would actually be billed per lesion. And so you do want to make sure that this information is conveyed in your report. So we may automate some of this for our reporting, but as a general rule, you want to mention the contrast agent and the amount that you administered. If you only gave 2.5 mils, you would say 2.5 mils. If it was 5, you would say 5. And then just a brief statement about how you use the ultrasound contrast during the procedure. So finally, start with a few big tumors, for example, in the liver, just to get comfortable with the workflow and the enhancement patterns of tumors, for example, in the liver or kidney. And I think that will help you get comfortable. And then when you're using it for smaller, more difficult lesions, it will be a cinch. So thank you, and if you have any questions, please let me know. Thanks.